Before starting, I just want to once again say that today, right now, I am because of my father and mother. I always, even though he's behind me, it's like his shoulders right now on me. So I'm confident, and also to all my gurus.
Yes. Yeah.
Who have helped me reach this stage, especially my professors, Janardhan sir, VKC sir, Ramesh sir, Rahul sir, Ravi sir, Kusmanjali madam. And also, I always call the elites of ENT as my Dronacharyas because I learn a lot by just seeing them. Like an Ekalavya, I learn what they are teaching. So everybody should be an Ekalavya, grasping the Guru's technique, whoever is teaching. So on that note, and I also thank Ravi Krishna uncle, Madhavi auntie. They are just
Good morning.
show them good morning. Yeah. They're selling good morning. And Madhavi auntie.
Okay. Good morning, Amma. Good morning, Dr. Madhavi.
The two people that are giving the excellent field, you have seen yesterday and you'll also see today. They just make us feel comfortable with the anesthesia that they give us. And for a surgeon, what more to ask than an excellent field? So now I'll just put the Boyle Davis mouth gag. And before starting, I just want to explain the anatomy of Eustachian tube a little bit and fossa Rosenmuller if possible, and then we'll proceed with the surgery.
Deepu, what is the anesthesia you have given and pre-medication?
Sir, this is general anesthesia. No pre-medication given. The regular inhalational anesthesia, sir.
Okay.
Propofol, relaxant, sedation. I think so. They've gone with fentanyl. Yeah.
Do they maintain hypotensive anesthesia?
Yes, sir. Yes, sir. They always do. Endoscopic picture. Light on. Light on.
You are using 4 mm scope or 2
No,
mm
no, sir.
scope?
This is pediatric. 2.7 mm.
Okay.
Yeah. Because she's 7 years old, so yeah. So you can see this is your
Endoscopic picture, please.
Yeah.
May I request audio visual? Thank you. Yeah. Thank you.
ట్యూబ్ సెంటర్లో ఇద్దామా
చూడండి ఇప్పుడు చూడండి మేడం ఓకే రిమూవ్ ది ప్యాక్స్ టు ద ఫీడింగ్ ట్యూబ్
Did you get the endoscopic picture?
Yeah. Deepu, we are getting.
Okay.
Deepu, you packed with that gauze you told.
Yes, sir.
Is this adrenaline with
Yes, sir.
Zercaine or only adrenaline with saline?
No, sir. This is 4% with adrenaline.
4% with adrenaline.
Adrenaline, yeah.
Do you put any xylometazoline in nasal drops before surgery?
No, sir. No, sir. So some papers have shown that it has a rebound hypertrophy. It blocks the receptors, and then again you can't again apply for certain amount of time to get the vasoconstriction.
Okay.
So usually it's not advised, but lot of neurosurgeons do that for the transphenoid surgery.
Okay.
The xylometazoline, even ENT people do, but now I think so everybody have shifted to 4% with adrenaline.
How much adrenaline you are adding, Amma?
Sir, for topical, I think so maybe you can even add 2 ampules without any worry, sir.
Okay.
Not an issue. Okay. So these are grade 2. This will be nice. Awesome. I'll just
are using debrider blade from other side, huh? Dr. Deepu, you are using instruments also same side with the same nostril, or you are using from other side? No, no. Acha, acha, acha. Dr. Deepu, we are not able to hear your voice. Audio visual, we lost connection. అక్కడి నుంచి రావడం లేదు వాయిస్.
Hello, Manideep, we are not able to hear your voice.
ఒక ప్రభాక్
యా మధు.
ఒక అది ఏదో బ్యాటరీ చూస్తున్నారు.
ఓకే ఓకే.
He just explaining the eustachian tubal anatomy,
యా
the torus tubaris, and you are asking whether the instruments are passed from the same nostril.
యా
Endoscope and elevator are passed through right nostril only.
ఓకే ఓకే.
Hello, hello.
యా Manidip, we are with you.
Okay, good, good. Yeah, a small hitch. Okay. So eustachian, just a second, uncle. I'll just
Okay.
take a minute. So the eustachian tube anatomy, the bulge of the eustachian tube is called the torus tubaris.
యా
And then the medial edge of the eustachian tube is called salpingopharyngeal fold.
Salpingopharyngeal
fold.
ఓకే.
I'll tell the importance later. Then the lateral edge is called salpingo-palatine fold.
ఓకే.
And the inferior edge, this is the levator veli fold.
ఓకే.
So why I'm telling this is everybody can remember easily. How to remember anatomy is to crack the code of etymology. Etymology is the science of origin of words.
యా
Because all our medical terminology is because of European people. We have the Latin predominance, so they are derived from Latin. So you can easily, why is it called salpingopharyngeal? Basically, dissect the word, two parts, salpinx. What does salpinx means? It means tube.
ఓకే.
And pharynx means the pharynx. So
Yeah.
the medial border, which is in contact with the pharynx, is called as salpingopharyngeal fold.
ఓకే.
And the lateral border, which is in contact with the palate,
యా
that's why it's called salpingo-palatine fold.
పాలటైన్ ఫోల్డ్.
And this inferior border of the coena, which lifts the palate,
యా
that's why it's called, the muscle is called also levator veli palatini. Veli means a wheel, a covering of the palate. Levator, what does it do? It lifts the muscle. So if you remember each word and the origin of the word, you can never confuse and know the boundaries and okay, what is medial, what is lateral. So immediately, a few seconds of your time, you can easily process.
దీపు, can you repeat levator palatine?
Yes, sir.
Veli.
Levator means lifting. Veli means wheel is like it's called as a covering in Latin.
కవరింగ్.
So it covers the palate.
ఓకే.
And palate of palatine because it is a palatine muscle. So
Yeah, yeah.
it three part. Why is it called is levator veli palatini? It lifts the palate
Yeah.
and covers the palate. So that's why it's named. And the good thing about naming anatomy is they have named the function.
యా యా
So if we remember how each muscle or joint or even ligament works, then you can easily remember the anatomy. And this goes with skull base anatomy because the head and neck anatomy has the most complicated names. Even in my first year, I used to feel like, oh, why this much of complication? So we'll proceed with our debrider adenoidectomy with that. Okay, white balancing done. So now I'm introducing my debrider blade, and one of the main advantages of using a rad adenoid blade is you can lift the palate without injuring it because the blade is on the opposite edge. See,
Yeah,
the
yeah.
uvula didn't get sucked. But in
Yes.
coblation, you have to pass an infant feeding tube to not get the uvula sucked into the coblation suction. Okay?
ఓకే.
And one more thing, I always say, your debrider blade at the mouth should never be in center. Why?
Okay.
Because your gag is there. When you want to reach the superior border of the coena, this will come in obstruction. So So when
Yeah.
you're trying to do on the right,
So laterally you are applying, laterally you are,
the beginners, all the PGs can do debrider adenoids without any issue, but when you try putting your blade here, they'll face some difficulty and they'll not be able to debride, or the debrider blade will touch the other structures and then it will be a panicky. So always pass from the opposite side so as to not get the Boyle Davis the debrider blade. Okay?
okay.
So one of the pros is this, sir. Using rad adenoid blade without infant feeding tube, you can lift the pallet. See,
Yeah, yeah,
I am lifting it
yes,
and not injuring the pallet.
okay.
So now pass like regular DNA. Okay. Yeah. So I can see my blade. Okay.
Yeah,
See, now I am able to pass in the superior border of the adenoids on the right side because I am
Yes,
coming
yes.
in a angled way.
yeah,
Okay. Foot pedal. Okay. So, not left foot. I'm a left foot pedal guy. No issue. This bleeding is not much. Yeah. So I'll start debriding. So with the second point of the using this blade, now I am moving with the gravity. So the tissue comes easily into the blade. First, always debride in the central area. Be gentle. Do not poke into the tissue. Let the tissue come into the blade because it has a suction power. Okay, I'm going slow, I'm going slow. Then up to perseverance rate you have to do. Now turn your blade. Why I have explained the anatomy is you have to debride the medial border of the tube, just this salpingopharyngeal fold, because the adenoid tissue would have also, the follicular tissue will be hypertrophied even on this. And our main aim is to clear the eustachian tube function.
yeah,
So debriding this, see, I'm not going on to the tube. I'm letting the tube, the medial border come to me. Okay?
Yeah,
So
yes.
this is crucial for beginners. Never ever put your debrider blade into the tissue. You will always be safe. Okay?
Yeah.
So this third advantage of why we love this blade is now I can pass my blade into the Rosenmuller fossa and lift the eustachian tube anteriorly and then debride. Even though I'm not seeing, as I'm not touching the tissue and I'm letting the tissue come to me into the blade, I am safe. And in this way, I can remove the fossa of Rosenmuller. Yeah. We can remove the tissue on the fossa of Rosenmuller and not injure the tubal cushion, which is essential for maintaining the integrity of the eustachian tube.
yeah,
And see, I'm already reached the perimysium. We can able, not perimysium, just above the, I'll explain, but with this technique, and one crucial point is you have to feel the resistance, because as you are not able to see the tissue, there are three things I'll explain once I pack, how the tissue is getting resisted onto the blade. That is crucial. This is more like seeing and also palpatory surgery. As Satish Jain sir tells, you have to up to reach the perimysium of the tissue. Then only you have removed the entire tissue. See, the bleeding is also minimal. Of course, it's very minimal grade. So again, I'm debriding here. This is where it bleeds the superior part. So now I have stopped. I want to go to the opposite side. Now once again, as you can see, this is crucial, sir, for beginners. Now I'm rotating my blade again to the opposite side.
Okay.
See, my blade is already
Yeah.
directed to the superior part of the left side of the coena.
yeah,
So never in the center, because the gag will always obstruct this. In
Yes.
my initial days, I didn't understand this. These are crucial points for beginner surgeons, because these are all observations that you get by doing each surgery. So passing this blade from the lateral edge is so crucial to have a clean field and a good dissection. So I'm passing. Once again,
yeah.
you can see some discharge.
Dr. Manideep,
Sir,
Is it pus coming from the nasal cavity? We are able to see some
Yes, sir,
mucus
some
discharge.
sphenoethmoid recess, there is some discharge. It was
Okay.
not there earlier, but I think so that is because maybe some sinusitis would be there because of the adenoid tissue.
Okay.
Sac.
Next to
The discharge comes. So dad is telling the decongestion of the nasal mucosa will make the mucoid discharge to come. I don't think it's unhealthy discharge. It's just the mucoid
Yeah, mucoid.
discharge. Yeah. So once again, I'm debriding the superior part.
The most important thing is you are allowing the tissue to come
Come
to
to-
you and you
yes.
are cutting it.
Debride.
That's
And
most
one more thing here for the PGs, even for exam sake, is the power of debrider, the RPM, is always inversely proportional to the cutting power of the tissue. That means if you have 3000 RPM, you'll cut more tissue, soft tissue. If you have 5000, you'll have less tissue in your blade. Why? I'll explain after once I pack. I'll show you how the blade rotates. It's a formula everybody can write in exams. So I'm debriding. So again, I'm working with gravity. Gravity is my friend here. So that is pro one, the advantage of our adenoid technique. I'm reaching till Passavant's ridge. I've tried with Satish Jain sir's technique, but it is only, I faced struggle because sir's hand and skill and anatomical understanding is something superior. So once again, sir, I'm rotating my blade. See, I've rotated my handpiece. I'll show how I rotated. This is also crucial. So my hand, I've rotated it, and I've taken support of the gag so as the blade should not slip. Once again, I am debriding the salpingo-pharyngeal fold, the medial border of the eustachian tube, the tube with pharynx. That is what salpingo-pharynx means once again. So just letting the tissue come, we can debride. Now, the third advantageous point of this thing, I am lifting the tube completely anteriorly with the non-debriding surface of my blade, and then again, as Vidyasagar sir says, coblation is hovering, even debriding force of Rosenmuller is hovering. You should never touch the tissue, let the tissue come, hover over that. Okay. So it's good. I think I've done a good job. You can just suction without debriding and then see any tissue is left. Yeah. We'll pack now, sir.
Yes.
So
excellent.
we pack with ferracrylium cotton balls. So my assistant takes a cotton ball and simply slides. And I feel packing with cotton balls is always good, sir. Cotton is a firm structure. It puts pressure. You are having a surface hemostatic agent applied to that, and you are also taking the pressure factor into this. And so both ways you are trying to have the hemostasis happen. So this is good for adenoids. I'll just see if there is any space. Take your finger and slide here. If you feel you can squeeze in, if you feel like you can squeeze in another cotton ball, pull up the cotton balls with your fingers like this, and then again put a dry cotton ball, but no, not needed, sir.
Okay.
So this is important. Can you show the ferracrylium bottle?
You are using liquid ferracrylium or gel?
No, sir, liquid, sir, because cotton ball will soak up with the liquid. It can absorb more liquid.
Okay.
This is the ferracrylium we use, Sepguard. Are you getting the external picture, sir?
Yeah, we are getting, we are able to see the bottle.
Yeah.
How
So-
much percentage, anything like that?
So this
Ferracrylium?
is also, I think so it gives 1% volume by weight.
Okay,
But
okay.
as it is topical, you need not worry, sir. It's like they'll pour in the cup, let all the cotton soak. If
Okay.
still the cotton balls are not yet wet completely.
How much time we have to keep?
Sir, once again, this is clotting time, sir. It's always better to wait. So it's already 9:05. 38 seconds. I think so. I've put around 9.5. So let's wait for 5 to